emphasize quite a bit. So you do want to consider that as a background as well. Okay.
원래 목소리 크잖아. ECG confirm. The first case of case, who will take it first? According to tradition, kill the people.
This is an issue. A white fluorescent tachycardia and in primary trend is B2 QRS in the V2, and then B1 is RBBT pattern and bit right bit here and all the QRS complex shows B2B variation, B2B variation. So I think it is probably speaking with
SVT was accuracy.
The white fluorescent tachycardia is irregular and
Is it irregularly irregular or regularly irregular?
irregularly.
Regularly irregular, so-called cardiac ballet, right?
And maybe
Yeah, look at B1. B1. Clear to me.
well, if with differentiation. Or how PV after the QRS. This is also possible. PV.
What is your interpretation?
Edition. SVT with appearance.
Aberrancy.
Yeah.
Then what kind of SVT you suspect? You told me you could see the P wave.
Yes.
And the QRS rhythm is regularly irregular. Okay, copy.
Yes, this is a broad complex tachycardia. The rate is somewhere around almost 200 thereabouts. There is group beating, so you have groups of 4 with a gap, and then that's consistently running throughout. But there are a lot of inflections in the baseline. So this looks like it's a P. There's also something here. I think this is also a P for a P wave, another P, and it consistently throughout. So I think, and again, looking at the QRS complexes, even though they are broad, there's some narrowness to them. It's not the typical kind of broad complex you get with a ventricular rhythm. So I would think there are 2 things going on. One, I think there's some pre-excitation. Was looking at how this flares up also here, also here. So I think there's pancreatization going on. Maybe on a background of an atrial tachycardia or atrial flutter with some intermittent conduction block because of the AV decrementation. So that's what it's a pre-excited atrial tachyarrhythmia, either flutter or atrial tachycardia, which is why there's a good beating.
So you thought the rapid QAV is marching through the forest of QRS.
Yes,
And
I think so.
QRS complexes are regular, make
Yes.
a group meeting. But why their first QRS morphology is a little different to the later three. And I wonder our interval is same or not. You see that?
Yes,
First
the first
QRS,
looks
yeah,
for
first
each
QRS
group.
is little QRS morphology is a little different.
Yes.
Okay, Henning, any other comment? Not only rhythm, but also in general, what kind of specific finding do you see?
Maybe we can suspect LV hypertrophy. And
Based on voltage criteria,
yes, based on high voltage.
and why is it first complexes are so wide?
Maybe due to systemic electrolyte imbalance or hi- systemic instability because the patient came to the ER and
Oh, how about you
Maybe.
know the patient?
oh no
No?
no
Okay, system condition. So we need to differentiate when you see the wide complex tachycardia. Number one, ventricular rhythm. Number two, Van der Waals block. Number three, functional Van der Waals block, so-called aberration. Number four, excitation. Number five, pace rhythm. Okay. Junyoung, please conclude and let's get the critics from Professor Huang.
I think this is the actual tachycardia to the conduction. Paris looks little wide, but not good wide, about 120 years. And there are three of P wave and the looks regular. PP interval looks regular. There are two.
Oh, did you measure it? 15 interval regular? Did you use caliper? That's the best way to. Not on the screen. If you have a manual caliper, you can measure on the screen.
He's eyeballing.
Yeah.
And that's what he think.
Regular, right? Regular PP.
Well, I think first, when you look at the complex arrhythmia, you want to see whether clear-cut visible P wave, right? There's one. What do you think about this P wave axis? Is it normal, abnormal? B1 is a markedly sharp positive, right? There's no biphasic. B2 has a biphasic, right?
B1 is
B1 is negative.
Yeah.
And then you got slightly positive 2-3 in AVF, but amplitude of a P wave is smaller than usual in inferiority you want to see it. And AVL, the definitely negative. Why? AVI is a positive. Is this a sinus or not? The first thing you need to know, right? And second thing you want to know, see whether P-QRS relationship. Dr. Park already pointed out you have a QRS group beating, the first one is wider than the other one. Looks like it gets slightly narrowish and then blocks something, pause, right? So what is that phenomenon called? You got long short sequence going on. So first bit is typical, almost like an Ashman phenomenon, right? And then why is it blocking down? HR rate or tachycardia rate is reaching the AV the Wenckebach. Then it's going to have a group beating. So whenever you see group beating, first thing you think about is this is a Wenckebach phenomenon. But since we know first there's a nice P wave, then you cannot tell where the second P wave is. But there you can tell, yes. Look at the V1. What do you see? You got a sharp P, and then first complex at the top of a T. There's a notching. In fundamental law of the EKG, you cannot have any other activity other than summation from other chamber deforming the T wave. Okay? Because that's absolute refractory period ventricle, right? So whatever the notching happen has to be other chamber firing. That might probably P wave on top of a T. But look at the relationship of that timing of that thing. Gradually disappear. You see that? Shorter into the QRS complex. Then you got P wave shows up again after block. So clearly atrium is driving, suggested that the ventricle. So this is a supraventricular tachycardia most likely. And then you have a group beating is a Wenckebach. And the first complex is wider because of Ashman type of phenomenon. As the acceleration goes on, QRS get narrower, ERP gets shorter, but also AV node blocks down. So that's why you have an AV node Wenckebach pattern here. Now, can you have other type of Wenckebach? Of course, if you have HR flutter and so on, there would be differential diagnosis here. But the rate of tachycardia is not fast enough to be HR flutter. Okay? Because HR flutter would go about 300 to 400 beats per minute, something like that. Below that would be HR tachycardia pattern. And also, EKG morphology not consistent of the flutter, right? Inferiorly, the P wave positive and so on, unless it's an atypical flutter. Now, why the QRS get narrower? Dr. Bach asked that question. First is wider, second again narrowish, and then what? So look at the axis of a QRS complex. What kind of block is this? Besides the left bundle branch block pattern, what do you call? Patient have a way up superior axis, right? Could it possibly this conduction with the anterior fascicular block kind of stuff? Yeah, because the patient does not have a typical left bundle branch block pattern here, right? And then also very unusual notching on the upstroke of V6. You see that? And this is unusual pattern conduction. So the patient must have some structural heart disease, but then I think it's tachycardia enhancing, causing significant aberrancy pattern, but not quite complete left bundle. So I think what we think we see here is possibly atrial tachycardia with the aberrancy, typical Ashman phenomenon pattern with the progressive block of AV node Wenckebach. And she pointed out there's a voltage criteria for LVH, but once we have an aberrancy, LVH criteria become a little bit more difficult. But in this case, you can, because the reason is because you don't have a complete left bundle here. Okay. Yeah. So that's.
I'd like to discuss about the QRS morphology. If you look at the V6,
Right.
it's like a quick citation,
Mhm.
but the quick citation cannot be shows a
Right.
ECG morphology like V1.
That's
So
correct.
there's apparent PR interval
Yeah.
when we see
Right.
the Q wave. So I don't back to quick citation,
Right.
but the QRS morphology is quite different to the typical type of aberrancy of
Right.
left bundle branch block. And if you see the V123, V12, there's small Q wave. So that is also unusual,
Mhm.
unless the patient has a septal fibrosis or something. So I think that this patient has some significant structural heart disease, associated structural heart disease, but I would like to listen to Dr. Huntington's thoughts.
There are too many things in the book. So,
Not diplomatic.
we don't have Thank you.
Any other comments? Junyoung, you try to tell something. No more?
Do you think that this P5E6 S-segment depression with the T-wave inversion, this is something unusual about this. Also, inferiorly, they have a little bit of that. So sometimes when patients have a structural heart disease, when tachycardia goes very fast, also can develop secondary ischemia. So you see some changes like that, but then obviously there's no classical pattern of other than B1, B2, Dr. Park mentioned, what possible scar in the septum. Other than that, we can't see much. But what is very unusual, striking about this tachycardia is that you can see notching in QRS every single lead. This is what really troublesome. Yeah, this is usually very sick heart in general. But I don't see, other than that, any other changes.
Okay.
Tell us about the patient.
I there was the patient. It's 20 years old and she complains
Uh-huh.
and dyspnea. That's the story. His mother has a Danon disease and heart transplantation.
Oh boy.
And he ran into variant fever, so he has a Danon disease and heart left and paroxysmal peak.
Okay.
His
Cardiomyopathy, yeah.
is mild cardiomegaly, but there's no pulmonary edema in here. CT shows increased LV and reduced global LV systolic function and granular sparkling and cogenity of myocardium due to Danon disease. Slightly worsened like regional motion abnormality and grade 2 mitral regurgitation and moderate pulmonary hypertension. When he do a coronary angio CT in 2023, no evidence of coronary artery disease. And 2025, he has a full 24 hours, predominant normal sinus rhythm and short-term AT and frequent PAC. When he go to CCU, this is the EKG when amiodarone infusion is capital. Amiodarone infusion. Okay.
It's also interesting ECG.
Yeah.
Okay, let's go to reverse direction.
But-
Dr. Junyoung. First. First, axis and also very similar to the previous.
Right. But then you have much more pronounced T-wave abnormality now.
Perhaps the morphology looks similar with previous EKG with notching and axis. And we also can see a P wave. Okay. Well, looks prolonged and irregular.
Next one. Look at the next one.
Yeah, one
Yeah,
of those.
little after that. Yeah, that one and next one. Yes, this is better. Yes.
So AT is ongoing, but the conduction velocity drop and then there are more blocks, so the ventricular rate is because of another.
Can you tell me why the lead 2 first to 3 complex? I mean 6 complex. The first lead 2 bottom tracing. Yeah, it's grouped in there, right? Long, short, long, short, long, short. What make you think about that? If he's a P guy. So you may think this could be a winky bug, or what other difference you could make? The first PR is longer, Second one is shorter. And then third one is longer again. Second is shorter, right? And next is longer. Second is shorter. And then continue for a while and then change that pattern. But based on that, you just pointed out that the two whatever HR activity there together, that's your baseline HR rate, almost like activated tachycardia slow down by amiodarone or flutter slow down by amiodarone, whatever it might be. But P wave is not consistent with the HR flutter. So what do you think?
Friend, actually, usually we see the two-tone conduction or three-tone conduction. It's
That's right.
5-2 conduction.
Conduction, but not like this.
Yeah.
Yes, that's why I'm asking this question. You understand what the Dr. Park's saying, right? Flutter is a mathematical model. So you should have a even number or odd number conduction pattern, similar, but then you suddenly change. So I'm just asking that question.
But then the later part of a rhythm street, the grouping is broken.
Right.
So probably the conduction change.
Mhm.
Anyway, five P wave and 2 QRS.
Right.
It's very unusual. Unknown disease is LAMP gene mutation. I just
What's that over there?
it's a lysosomal associated membrane.
Right.
protein.
Mhm.
So infiltrate disease and sometimes
Yeah.
misunderstand to different. We need to differentiate from the hypertrophic cardiomyopathy.
And also Fabry disease. This is very unusual.
Also neurological
Right.
and skeletal myocardial
Yes.
muscular disease.
So patient usually often not present as the cardiac. First is skeletal muscle deficiency, okay, handicap. These people die from the respiratory failure, not from the cardiac disease in general, because that's the more worse. This patient has a poor prognostic history tell you already pulmonary hypertension, so not going to do well. So question is, I try to answer your question. What do you think about is there underlying flutter going on in top of that? If you have a fast and slow conduction going on AB node, fast pathway, slow pathway, alternating, is that possible explanation here? Yes, it is. So, yes, absolutely. Yeah, it is something. So EKG interpretation, you guys do procedure every day in your lab. You need to start thinking those things integrate into your clinical practice. Okay? Yeah, it's important. Yeah. Because the patient has so many frequent PACs, atrial fibrillations, so other things like that. So they are predisposed to develop fast or slow pathway conduction mechanism as well, top of the whatever going flutter pattern.
Based on the P wave, the axis interpretation, V1 positive, and we saw the negative P wave in lead 1 and ABL, lateral precordial lead, and positive P wave in ABL. So probably comes from the left side pulmonary vein,
Right.
after pulmonary vein. So this patient is half rep and apparent symptomatic atrial ectopic tachycardia. Do we need to run the tachycardia?
No,
Why not?
our complication rate is very high, this patient.
But we need to save this young man.
Why? But then, the amiodarone, you try match as drug as possible. But because your chance of maintaining sinus rhythm successfully, this patient is very unlikely, acceptable for even the age. Because look at the P wave, that the B1, how tall that thing is. The severe pulmonary hypertension this patient has. So procedural complication may not be trivial. So how do you maintain oxygenation during the procedure? All that going to be, think about it. So I would not jump right into it. That would be a progressive ablation therapy would be the last choice of this patient. Okay, ventricular rate control, much better than before. I think stabilize the patient with the pulmonary hypertension or respiratory failure first. I would do the PFT, it's best definitely PFT, to look at where the pulmonary reserve is before you take to the lab. That would be advice for you.
Do you need to screen everything
Yes,
if it is safe?
then you can
We
do it.
can.
Yeah, and
But
then
the-
procedure as a minimum approach,
Yeah.
not the extensive business. Maybe PFA would be good for this patient. Quick. Yeah.
Oh.
Boom, 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 you're done. That's the only reason I say. Okay.
But even though after resolving this activator tachycardia,
Right.
this is progressive.
Progressive.
Disease.
And the only concern I have is that when you do transapt of this patient, it may develop persistent right-left shunt. Okay, it's very, very careful. So echo, blood pressure measurement, all these things count to your practice. Okay, so don't jump into right on. I'm gonna blade. No, you're gonna make the patient worse. Okay, so don't.
Oh, they did that. He's the most aggressive. Resistant. That's the worst.
Yeah, I think it's a difficult patient. What to do? More patients get complicated, make a decision very slow. Think carefully, okay? Then you decide. Ablation not always answer. So if not something they want this patient.
This is my first time to see the arrhythmia ECG of Damon.
Oh,
Any other slide? And
tell us what happened to the patient.
oh, yeah. What did you do?
I think the testing individual cardiomyopathy, I think so. I was that GMT, he has a hot rep, and when his condition is okay, I think ablation, atrial ablation is good for him. I think so. When GDMT starts and when condition is okay and when EF is more over than here, I activate into ovulation is the option.
How was the patient's daily activity?
Oh, his daily
fine.
activity is fine.
So you get a PFT first, make a look at the pulmonary reserve. Second thing is that certainly long-term amiodarone would not be good for this patient, definitely. But the problem of cardiomyopathy is not generally from the tachycardia, because your heart has about 30% skeletal muscle. So this patient develop cardiomyopathy because of that. So you can see in the chest X-ray, if you go by chest X-ray, you have global cardiomegaly. This patient, look at that X-ray. So it is more muscle mass, you have a more heart failure you develop. Another main concern would be how to resolve pulmonary hypertension in this patient. If you look at the chest X-ray, look at the subaxillary X-ray, how much muscle mass this man has? Not much. There's a normal X-ray for the 22-year-old guy. So when you look at the X-ray, you're just not looking at only heart and chest. You're looking at the patient's muscle mass and whole 9 yards. That's what you do. You're a cardiologist. So it is very poor. And then I would definitely consult also rehabilitation, pulmonary guys. See how do you gonna rehabilitate this man. So it would be important respiratory exercise and physical therapy. All this is going to be important. So I would do all that, and then you take to the lab of blade if you want to do it. Okay, that would be the best.
Another question? Okay, thank you. Okay,
Great case.
Yeah.
Appreciate it.
for sharing the last two. 이 계속 송출되고 있었던 거야?